So good morning, everybody. I'm Dr. Ashish Nabar from Mumbai, and I'm the coordinator for this Indian Heart Rhythm Society DNB, that is the Cardiology Postgraduate Training Program that we have once a month, first Sunday around this time. For last 4 years, I keep on saying proudly, and that's largely due to the efforts of the faculty of the Indian Heart Rhythm Society, which very willingly obliges to create at least 4 to 5 presentations around a particular theme, and then this session equally easily gets chaired by two personalities from the IHRS senior faculty who very kindly and very eagerly oblige. And I hope it serves some purpose in addition to what the postgraduates train in their own departments. Now, yes, truly, almost say 10 out of 12 times in the year, we have the IHRS faculty doing the program. But 2 or 3 times in the year, we also invite international faculty, and a good number of luminaries have presented on this program, and it gives a different flavor and a level to the program. And I think our postgraduates probably do enjoy that. So there are a lot actually training on this program, and every time I earn for more to join. Today I can see at least 60 or so have joined, and through the program I think more will join us. Now there is an interesting element to today's program, and I'll not spend too much time on that. But I must say that starting with Dr. Yash Lokhandwala and then me, and then I think Daljit visited Maastricht for some time, and Dr. Jayaprakash or Professor Jayaprakash Shenthar from Jayadeva, Bengaluru, presented his thesis through the Maastricht University. And we have all earned a lot out of Maastricht, starting under the leadership of Professor Wellens. And we humbly acknowledge his credit to our learning electrophysiology in India as a whole. The second thing probably is that when I was training, and probably also Yash, Paul was then doing his thesis, and I am completely mesmerized by the way he has grown through the ranks and is now a professor of cardiac electrophysiology at the department. I understand from him that he has a big team of PhD scholars training under him. And I want to learn what I have missed in last, say, about 20 years since I left Maastricht from Paul. And that's how I reached out to him. And surprisingly, without any ado, he easily, without any fuss whatsoever, he easily agreed to come on the program. So thanks, Paul, for agreeing to be to do this program, create a theme which suits our postgraduates, and also get along your colleagues who would be kind enough to come and teach us also and our postgraduates. So the program today is outlined there on your screen, but I would let Paul do the speaking on what his thoughts were behind this program. Can we have the next slide? Monica, can we go through the next slide? Yeah, so I think I said a couple of these things already, that we have it on the first Sunday and we have it for 1.5 hours. The only kind of discussion that I have with the host faculty is to kind of keep the program tailored to the postgraduate learning, so that they remain interested as they are in any intervention programs and imaging programs and things like that. So that's the only kind of focus I ask them to maintain, and the rest is entirely to their experience and what they feel right to speak about. Yeah, next, please. These programs, all the recorded programs of the last 4 years, are available on the IHRS website. You don't have to be a member. You just log in and you can review these programs at your free time, at your will. You don't have to be IHRS member, and you don't need a login code. And our secretaries of past and present, currently Dr. Rakesh Yadav, previously Dr. Vanita Arora, both have taken special efforts to put this program on the website. And due to the backing of the presidents of the IHRS, so Dr. Yash Lokhandwala was the president when we started this. Dr. Ullas Pandurangi is the current president. And under the full backing of the EC led by them, we are able to do this program in a pretty regular manner. Next slide, please. And of course, you need some kind of support to do this program, both financially and also structurally, to have this kind of a platform. So we thank Sun Pharma for doing that for us. So I think I'll not spend much time. It's a very interesting program. Paul, this is not a very formal meeting. It's pretty informal. So although we have budgeted some times, we can exceed in the interest of the students by 15 or 20 minutes if we kind of go over the time. That is not much of a concern. So I think I'll let you take the stage and take over the program. Paul, the stage is yours.
Thank you very much, Ashish. Dr. Nabar, I should say.
No.
Well, it's an enormous pleasure for us to join you this morning from Holland and this night from Argentina. I will start sharing my screen. And if it works now, well, you can see it. The presentation mode is opening.
Yes, it's on for us. You can just go on full screen.
Okay, good. You've seen the program, you all, and again, we are excited, we are delighted that this invitation came, and with so many good memories, as I will explain to you in the upcoming minutes as an introduction to the program and to the content of the meeting. It's 8:05 in Holland, it's 3:05 in Argentina. A kind hello to all of you. Well, maybe just to give you a bit of an impression of where we are, if you take the globe and you take the map of Europe and you ask a big fly to sit on the map, then you will not see Holland anymore. We have a very small country. But it is located somewhere between the United Kingdom, Germany, and Belgium, and the dark blue content, as you can see it on this screen. People from outside believe we wear wooden shoes, or we live in windmills and we buy tulips to our partners every day. But maybe that is a bit of the old-fashioned way of looking to our country. We have many modern aspects, and I think it's fair to say that we have some impact to the global view on cardiology, mainly by the contributors from our country. Maastricht in the south of the Netherlands is about 2.5 car drive hours away from Amsterdam, and less so to Brussels, about 4 hours from. I hear a background noise, or it's a voice. Is that a purpose? Should I continue?
Sure, Paul, that's from my end. I've shut it. Sorry.
So, Maastricht in the south of the country, beautiful city, Roman ancestry. It has 2,000 years old, with a big river flowing through. And if you are interested in the weather today, it's put there at the right lower corner. It's about 10 degrees later today with a lot of sunshine, probably much cooler than where you all are in India. In the middle of the screen above is our Maastricht University Medical Center. And if you put that at larger scale, this is exactly the place where Dr. Nabar and Dr. Lokhandwala have worked in their days when they were with us in Maastricht. And Maastricht University Medical Center is the combination of the hospital, the academic hospital where people are trained. It is the Faculty of Health, Medicine and Life Sciences at Maastricht University. And it is the Cardiovascular Research Institute Maastricht, where all the overarching organization for our cardiovascular research is organized. The Cardiovascular Research Institute is an institute that binds all kinds of disciplines in research that are actually our cardiovascular system, the heart, the blood, and the vessels. And just to give you a few key figures, and we will not dwell on many numbers, but just to give you a few impressions, we have an annual budget of more than 20 million euros. There is about 160 FTE of researchers working with more than 100 PhD students internally. There is about 1,000 peer-reviewed journal articles with an impact factor on an average of 6. And in 2023, we had we had exactly 63 PhD thesis defenses. This is my team, and this is the team that I'm extremely proud of in the field of the complex arrhythmias, and in particular ventricular arrhythmogenesis and genetic cardiology. People in scientific staff, we have a junior postdoc who's actually presenting just after me in a minute. There's many very talented PhD students. There's also very dedicated support staff. We have external students and external PhDs, including Dr. Rivera, who you will see in a minute, and the second presentation. We have research nurses, and we have a lot of funding from both the country and the European Union. What do we do? Well, this is it in a short snap. We are mainly involved in translational electrophysiology. That means we cover the spectrum from patient to the DNA and everything in between. My own PhD work in the 90s, when Ashish was with us, were on cellular electrophysiology, and later on this integrated into the beating heart. We investigate many aspects of arrhythmogenesis many times with the question, why? Why is this arrhythmia occurring as it shows? Why is it so deadly? And how can we prevent it from recurring? And we focus a lot on doing better as cardiologists in phenotyping the heart, because we need to know better what it is all about that these arrhythmias come forth. Now, that is now, and there is also a then, there is a past. And of course, you recognize this from your own city, from the city of Mumbai, the gateway of India. But there is also then in terms of, history to the department. And on this screen, which is from 1994, you see at the right side, Professor Hein Wellens, already mentioned by Ashish. And at that time, we also had a very nice visitor from your country. Yes, this is you, I believe.
Yes, Paul, with some black hair.
With some black hair and glasses. We were extremely proud to have you then. And as you can see in these relationships, and that is also very important for the audience at large, if you build into relationships, you can foster them for generations afterwards. So that is Yash. Of course, I have another picture. This is 1999. Again, you recognize the big man, Professor Hein Wellens. But there is another one, a little smaller, and that is Dr. Ashish Nabar, when he was with us, and in the year that he defended very nicely so his PhD thesis, radiofrequency catheter ablations for atrial flutter and atrial fibrillation. I was his para-nymph at that time. That means a kind of helper, a bridesman if it was a wedding. But we had a fantastic time together during the defense and afterward. Now, that brings me to the program of today. I would like to introduce to you shortly the speakers of today, of my team. The first being Dr. Job Stok. Job is a postdoctoral research fellow at our Department of Cardiology at the Cardiovascular Research Institute, who studied technical medicine at the University of Twente in Enschede and graduated there in 2018. And then afterwards, he came to work with us for his PhD, which he very successfully defended in 2024 in February of this year, entitled Multimodal Image Integration to Better Explain Human Ventricular Tachyarrhythmia. Thereafter will be Santiago Rivera from Buenos Aires, who became a cardiologist in 2009, now heads the Cardiac Electrophysiology and Clinical Research Unit at Accord Health Medical Center and the Acorena Clinic in Buenos Aires. Santiago studied medicine at Universidad Austral in the same city, and he got his MD in 2004. And with all the fantastic work he's doing for his own PhD thesis on papillary muscle arrhythmias of the left ventricle, he will defend his PhD next year in Maastricht. And then we have Dr. Rachel Terbecke, staff member in Maastricht, cardiologist since 2011. Rachel is a clinical electrophysiologist and a genetic cardiologist at our department. She studied medicine at the University of Antwerp in Belgium and graduated cum laude in 2002. Her PhD title was Ventricular Arrhythmogenesis in the Genetically Susceptible Heart, and it's time to change concepts of mechanisms and management. And if we can do that also a little bit today, then we are satisfied. With that having been said, I will now give the floor to Job Stocks, unless Dr. Nabar would like to mention something in between. If not, then I will stop sharing and I will give back the podium to the next speaker.
Okay, thank you very much, Paul, for the introduction. Is this visible for everyone?
Yes.
Okay, great. Yeah, so thank you very much for having me. My name is Job Stocks. I'm a postdoctoral researcher, and I will be talking about electrical activation and recovery in the normal human heart revealed by non-invasive electrocardiographic imaging. And to start with, I would like to start with a couple of open doors that, as clinicians, I'm sure you are very well aware of, more than me. But still, it's good to recapitulate a little bit. Firstly, the diagnosis of a disease is based on the comparison with the normal situation, right? So if someone has a broadened, widened QRS complex on the 12-lead ECG, we compare it to the normal situation, and that's how we know that there's some conduction impairment. And secondly, physiological knowledge is required to diagnose and treat pathological conditions. So if we didn't know that the ventricles had bundle branches, we would not have known that a bundle branch block then causes this widened QRS complex. Compared to the normal situation. So I think this physiological knowledge is really vital to have before we start investigating pathology. And what do we actually know about the normal ventricular electrocardiography? Well, I think we know a lot about the normal 12-lead ECG, right? There's a very elaborate list. I have mentioned a couple of things on the left, but I'm sure it's not complete, about what is the normal ECG supposed to look like. You know that the QRS is supposed to be less than 100 milliseconds, no pathological Q waves, concordant T waves, and so on and so forth.
Job,
So
sorry, I'll interrupt you a bit. Can you speak louder that it's more audible?
Okay, I'll do my best. Is this better?
Yeah, that's better. Yeah, sure.
Okay, great.
Thank you.
No problem. Okay, so that's quite an elaborate list of knowledge that we have on how the normal ventricular electrocardiography is supposed to look like. However, the downside of all of this is the 12-lead ECG is essentially a satellite image, right? Because we want to know what's happening in the heart, but we place the electrodes on the body surface and the extremities. So we're always looking at it from a distance, while the real action is taking place inside the heart itself. If you want to look deeper into the heart itself, an example that you could use is, well, this very nice study by Dirk Dürre and Circulation 1970, in which they explanted human hearts and they used a lot of high-resolution transmural needles to look into the activation patterns of the normal human heart. And what they did is they looked at the activation patterns, and for example, you can already see that the first endocardial breakthrough happens on the septum, and the last activation is, for example, the LV lateral base. But still, unfortunately, these are explanted hearts, right? So if we want to know about the in vivo situation, then this current experiment, it lacks quite some components. The autonomic nervous system, of which sympathetic and parasympathetic influences, hormones, baroreceptor feedback, mechanoreceptor feedback. So to really know about the normal in vivo situation, we should study it in a live human. And for that, you could, for example, use electrophysiological studies and contact mapping. These provide local information of very high resolution, but unfortunately, they are invasive and time consuming, and they would not be ethical to perform in healthy volunteers. So there's quite a lot of modalities that we can use to study the normal ventricular electrophysiology, but none of the mentioned above have been perfect to do this. I'm not saying that the next one is perfect, but still, I think we get a good image when we use electrocardiographic imaging or ECGI. ECGI is a combination of very extensive body surface potential mapping. We use about 250 electrodes that we put on the subject's torso, front and back, and also a CT scan or an MRI scan to image the heart and the position of the electrodes. So what we end up with is a lot of electrical information on the body surface. We know exactly in the 3D space, because of the CT scan, where this information was captured, which potential is where. And thirdly, we know the shape of the heart amidst all these electrodes in the 3D space. And if we then use a mathematical model to reconstruct we can reconstruct the epicardial electrical activity. So at each location of the heart, on a beat-to-beat basis, we can look at the full image or a capture of it of the electrical activity. So we reconstruct these epicardial unipolar electrograms, and by looking at these electrograms, we can then reconstruct activation and recovery patterns on the heart itself on a beat-to-beat basis. And ECGI, of course, has also been validated here in Maastricht. This was in 2017. And this is the experimental setup. It was used in dogs for the validation study. In blue, in the experimental setup, we can see the body surface electrodes surrounding the dog torso. In green, we can see the heart. And in red, we can see an invasive gold standard, which is an epicardial electrode sock. If we then use ECGI, we can reconstruct the epicardial activity and we can compare it to the gold standard, to the actual situation. And here we can see a couple of comparisons of the electrograms of ECGI compared to the invasive ones in black. And if we then look at the activation and recovery patterns that ECGI is able to retrieve, we see that the R compared to the gold standard is 0.82, and for recovery it's 0.73. If we then try to estimate the location of the first epicardial breakthrough, we can see that it's about 10 millimeters off. So to summarize, ECGI is not perfect and high resolution as invasive measurements, but still it provides a good global image of activation and recovery patterns. And this allows us to investigate it in normal humans. To persuade our quest of investigating the normal ventricular electrophysiology. And this is a study that we performed in collaboration with Imperial College London. And we investigated exactly this in 22 normal subjects, of which 6 were male, 16 were female, 11 were lower than 50 years old, and the other 11 were 50 years or older. And by using ECGI, we reconstructed the activation times on the left, from black is early to white is late, and the recovery times on the right, from black is early till green is late. And lastly, we then transformed these epicardial results onto an epicardial bullseye, which looks like this. So mind you, this is not the standard AHA 17 segment LV bullseye containing the LV septum too. No, this is an epicardial bullseye. So In blue, we can see the right ventricle, and red, we can see the left ventricle. The mid of the bullseye is the apex, the surrounding ring is the base, and as we move from top to bottom, we go from anterior to lateral to the inferior side with the septum in the middle. So this provides us with a standardized way of looking at these activation and recovery patterns. And this is what it looks like in two representative examples. On the left-hand side, we can see the activation and recovery patterns in a female subject, and on the right-hand side in a male subject. And already we can see the location of the first activation as often on the RV lateral or anterolateral base in both subjects. And moreover, what we can already see in this example is that even though our intervals were quite similar in these subjects, recovery is typically shorter in males. And if we then try to summarize all of our population results of first and last activation and first and last recovery, we can see that most subjects have their first activation on the RV anterior base. And for the last activation, it's either that same location or it's the left ventricular infralateral base. For recovery, as you can see, there's a little bit more dispersed. And if we then compare our results to the invasive study by Dirk Durre in 1970, we can see that our results align quite well. And now I come to the most important part of my presentation, which is, well, these 22 subjects, they were found to be normal. So they had normal echocardiograms and normal 12 lead ECGs. As you can see, based on this example from just lead 2, the 12 lead ECG and these 22 normal subjects, they were quite alike. However, based on this information, you would also have expected that the underlying epicardial activation and recovery patterns are also alike, right? But to our great surprise, this was not the case at all. So if you compare the activation patterns, but also the recovery patterns of these 22 subjects to each other, we can see they are very, very different. So in other words, each individual has his own cardiac electrical fingerprint. We also quantified this. So we looked at the correlation coefficients between subjects of the 12 lead ECG, the activation time and the recovery time patterns. And as you can see, based on the color coding, the 12 lead ECGs, they were relatively alike with a correlation coefficient of 0.6 or higher. But if you compare the activation or recovery patterns on the epicardium, these were very different because they're a lot more red or even black. They correlated less well. However, it is very good to still know that these activation and recovery patterns, they remain relatively stable within the subject over the course of multiple beats. So for example, if you look at the example of subject number 1 over here, we reconstructed multiple consecutive beats over the course of seconds to minutes, and we can see that these were quite stable. Same for subject 12. We also quantified this into correlation coefficients, and indeed, this heat map becomes a lot more white, indicating that the within subject correlations were quite high. And of course, now we saw the spectrum of normal subjects, but still that begs the question, what would happen in pathology? For example, in a pathological case of activation or recovery pattern, what would that look like? And I'm just going to briefly go through this, but if you compare the normal situation, for example, sinus rhythm in a control subject with a very short activation time, all in black or dark red, to a PVC or to a bundle branch block patient, right bundle branch, left bundle branch, or left bundle branch block with BIF pacing, you can see that activation was severely prolonged, also on the epicardium in those cases. And this also goes for long QT syndrome, in which recovery patterns are impaired. If we compare the normal subjects recovery pattern to those of long QT syndrome patients, you can see that the recovery time really prolongs in these cases. So the implications, what can we do with all this? I think baseline characterization by ECGI enables the development of electrical heart disease. It also enables to monitor the progression of maybe even subclinical electropathologies and arrhythmia. And of course, that has also been done in the literature. For example, ECGI has been used to characterize long QT syndrome, Brugada syndrome, really look into the mechanisms of these diseases further than what had already been done before. Also, arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, something that Professor Woldos will be talking about more later on. It's idiopathic ventricular fibrillation, CRT, and also VT. Sometimes even in subclinical cases, as you can see on the right, for example, in HCM. And I've been talking about this electrical fingerprint now quite a lot, right? And it differs a lot for each subject. And if we look at the field of arrhythmia, I think this is only one piece of the puzzle. So in the apparently normal human heart, I think there's a lot of different parameters, different dimensions that we can think of, both on the anatomical and the functional scale, that may influence an individual's risk of VT or VF. Examples are the Purkinje network, which is very personal, the conduction system anatomy, the moderator band, the papillary muscle connection, which we'll be talking about later, ion channel expression, travicularization of false tendons, the autonomic nervous system, transmural activation patterns, but also hormone levels. So I hope that I could inspire you a little bit on one piece of the puzzle, why the unlucky combination of several of these different factors may just put someone with an apparently normal heart over the edge towards experiencing arrhythmia. And with that, I would like to thank all of our collaborators, firstly, and also all of the attendees here for your attention. And I will now take any questions. Thank you.
Thank you, Dr. Stokes. This is Ullas. I'm from Chennai, and I'm thankful to all of you people who are sharing your knowledge with us. So I am going to be the moderator of your talk. It's a great presentation, and what I understood from your talk, and most likely all the attendees agree with me that they also have learned few things, and that is this non-invasive ECG imaging. It's ECGI is a very powerful tool which gives a very high resolution of the epicardial activation pattern and the recovery patterns. And compared to ECG, it is almost like an epicardial invasive mapping. What we do, that's almost the same kind of a resolution. Let me ask you a few questions. This activation pattern and the recovery patterns are well elucidated in your presentation. Do you also look at the amplitudes of these potentials recorded?
Yeah, thank you for your question. In Maastricht, we do not. It differs per implementation of ECGI. There's many different kinds and forms. Ours has its own validation and its own advantages and disadvantages. But unfortunately, one of the disadvantages is the mathematics behind the implementation we have in Maastricht does not allow us to look into amplitudes of the epicardial potentials.
If there is a potential to look at the amplitudes, I was thinking it could be even extrapolated to the endocardial potentials, and that would give a lot of clue to the the anatomical substrate, I was thinking. The next question is, with all that knowledge we get it from this ECGI, if you incorporate the signal averaged ECG information, which essentially gives the information regarding the latter part of the QRS or the latter part of the activation, can this be, more informative?
Are you proposing to combine both the signal average ECG and ECGI within to one, or
this itself, could it also be used further? You can all. I was thinking you could two data sets. One is your ECGI and another one is SACG. Can they be clubbed, and then so the information could be much more productive? Or this ECGI itself could be used as a SAECGI.
Yes, I think that would be a very interesting research question. If you look into the signal average ECG and when it's abnormal, what would ECGI tell us? What is the underlying epicardial substrate that we're looking at? So how does it localize on the heart itself? I think that would be very interesting to investigate.
Yeah. So finally, I would like to ask you a question. You see, now artificial intelligence is being used in ECG reading a lot these days, especially with respect to the atrial fibrillation. You can detect the possible occurrence, or even some prognosis also could be made before the actual occurrence of the clinical event in the form of atrial fibrillation. So similarly, if you have this ECGI data, you are looking at the utilization of the AI in the coming years.
Yes, I think so. This is actually something that is actively being worked on as well. Personally, I'm a member of the Consortium for Electrocardiographic Imaging as well, which is an international consortium of people working with or on ECGI. And we have a specific AI working group as well. Besides that, in Maastricht, there have also been implementations of ECGI without the imaging, so not to make it easier by using AI. I think AI and ECGI could be a very interesting combination, but we do need to be aware of, if you compare the 12-lead ECG with ECGI, then ECGI is a lot more complex. So if you want to perform AI on it, you would require a lot more data before being able to extract a message from it. But apart from that, yes, for risk stratification or looking into disease mechanisms, I think it could really add another dimension on top of the physiological and pathological things that we've been looking at until now.
So before I ask my co-moderator, Yash, I will have another question to you. Based on this information, what you acquired from the ECGI, were there any kind of a validation you have done with respect to the invasive electrophysiology studies, and you found the substrate, either an electrical substrate or an anatomical substrate? Have you validated in few cases?
Yeah, so firstly, of course, there was the dog study. I don't know if you saw it in one of the first of my slides, which is kind of the technical validation of ECGI, right? So my predecessors, my colleagues, they validated how accurate is ECGI in general and reconstructing activation and recovery time patterns. Secondly, there have been validation studies, and we have also looked into this ourselves. And for example, if we try to locate the VT exit with ECGI itself, then could it be of added value to clinical practice? And I think the answer is yes. We are now also using ECGI to non-invasively help the electrophysiologist before the procedure to guide it a little bit. Does that answer your question?
Yes, yes. Thank you, Dr. Joost. And I invite Dr. Yash for his comments or some questions.
Yeah, No, Ullas, I think you covered the ground that I was also asking questions. It was a nice insight into the something different for us. And thank you, Dr. Stokes. I think we will go to Dr. Santiago for his talk on the anatomical determinants of the polymorphic papillary muscle arrhythmias.
Thank you very much.
Well, thank you very much for this invitation. It's an honor to be here and sharing this presentation with all of you. I hope you can see my screen now.
Yes, we can see your presentation.
Well, great. So I'm going to go through the anatomical determinants on papillary muscle arrhythmias in apparently normal hearts. But let me first start by going through the normal anatomy of the papillary muscles. As we know, these are conical structures which project to the LV cavity, and they are usually solid structures, and most frequently you can observe bifid configurations. These have irregularly distributed fibers from the histological point of view, and these fibers are intermixed with conduction system. When we refer to monomorphic PVCs or papillary muscle arrhythmias, we usually get this kind of ECG where the arrhythmia is consistently showing the same morphology or the same IHRS configuration. And from the therapeutical point of view, these are pretty straightforward arrhythmias to map, as they have or they usually have a single site activation. Pace mapping can also help to the mapping process. And from the ablation point of view, when we are using intracardiac ultrasound and integration of the intracardiac ultrasound into the mapping systems, then it makes it more easy to target and ablate these kind of arrhythmias. And if you go back to the results of catheter ablation on mostly monomorphic papillary muscular arrhythmias, then we'll see that when you use this kind of technology, I mean ultrasound integration, contact force sensing catheters, or either cryoablation, then results are pretty good. That's over 85% success rates. And mostly it helps to overcome some issues like stability and contact, as with cryoablation, that's almost always achieved. But there's a different situation, and this is what involves polymorphic papillary muscle arrhythmias. These represent almost half of the patients with papillary muscle arrhythmias, and there's different situations in which you can observe these multiform arrhythmias. This is a good example because you can see that what seems to be a monomorphic arrhythmia actually has 3 points of discrepancy. The box number 1 shows that lead 1 has an alternating beat-to-beat between the PVCs, in which amplitude varies significantly. Then if you move to V1, you see that the configuration pattern of the right bundle branch block is completely different from one beat to the other. And finally, and most interestingly, is that in B3, you can see that each beat has different transition zones at the precordium, one being an early transition zone in the first PVC and a later transition zone in the second PVC. This is another example in which a patient with papillary muscle arrhythmia can show polymorphic non-sustained ventricular tachycardia. But the QRS variability issue is kind of interesting because it has been historically attributed to anisotropy and the fact that these arrhythmias can originate from either the myocardium, from the papillary muscle, or from the fascicular tissues that is embedded between them. But there are some other reasons that may better help to understand some issues like those regarding the QRS transition discrepancy bit to bit in the same patient. So for this, we had an hypothesis in which I will go over through. If you look at the left panel of the screen, you'll see that in patients that have double or multiple exit or multiple ectopy at one papillary muscle, no matter at which location, either at the head of or the base of the papillary muscle, the arrhythmia or the ectopy should always be forced to exit through the papillary muscle base. That's for the posteromedial or the anterolateral papillary muscle. This will always account for a transition zone, which will want to be around B3 or B4, as it's making reference to a mid-ventricular activation. But sometimes, as the ECG we previously viewed, transition zone may vary in the same patients and show a later precorded transition. And when you have a late precorded transition, that means that you're activating the myocardium more next or more near the mitral annulus. So the only possibility for that to happen is whether the papillary muscle has a connection away from the base that is aiding that ectopy to exit more towards the basal aspects of the LV. And that's what we observed in this patient. And you see here at the right panel that this posteromedial papillary muscle has these same connections away from the base and near the mitral annulus, and you can see the arrow marking that connection. Moreover, we can also figure out some connections that are actually connecting both papillary muscle in an Y-shaped structure. Many connections have been depicted, but in what's polymorphic papillary muscle arrhythmia anatomy, when we compare the results of the anatomical substrate of these patients against those with monomorphic arrhythmias, we see that the number of papillary muscle connections are more prevalent in polymorphic arrhythmias, and this means almost 10 times the number in patients with monomorphic arrhythmias. Then we also see that the architecture of the papillary muscle has somehow been altered, and it's formed with multi-stranded papillary muscles, and the LV trabeculation in these patients is also more pronounced. When we speak about LV trabeculation, we mean that the trabecular ratio tends to be higher than 2.3 in the polymorphic group, and the trabecular mass, it's almost 20%. That's compared to those with monomorphic arrhythmias which do not have this kind of prominent trabeculation. And to summarize these findings, we see that in the polymorphic arrhythmia group, we tend to find a higher count of papillary muscle connections, prominently those which connect both papillary muscles. Here it's marked with the white arrow, and then the presence of multi-stranded papillary muscles. When we first started the presentation, I've mentioned that normally we expect solid papillary muscles, as we see here in the anterolateral one, but when we speak about polymorphic arrhythmias, we found out that most of the papillary muscle are composed with several strands, and you can see here 1, 2, 3, 4 strands that make up the whole structure of the papillary muscle, in contrast to those with monomorphic arrhythmias that shows either solid or bifid configurations. And finally, the level of trabeculation, which seems to be more pronounced in the polymorphic arrhythmia group. Then, interestingly, we found out that in the polymorphic arrhythmia group, these patients may express something that we called bidirectional papillary muscle arrhythmia. And you can see here these ventricular couplets that are located at the papillary muscles. You see that the precordium has a right bundle branch block configuration with different transition zones. But the most interesting fact is that if you see the QRS axis, it alternates from negative to positive, given account that this first beat might be originated at the posterior medial papillary muscle, and the second one at the anterolateral. And when you go to the invasive evaluation of this, you can even make activation maps of both papillary muscles using ultrasound integration. And here you see the earliest activation at the base of the posterior medial papillary muscle, and then the earliest activation at the head of the anterolateral papillary muscle. Interestingly, in this same patient, when you go back and review the cardiac resonance imaging, then you find out that there's a connection, a very complex connection going through both from one papillary muscle to the other. The same thing may occur with the outflow tract, and this is a very interesting case in which a patient presented with a first PVC that suggested a outflow tract origin, but he also had two different PVCs. The second most frequent was the one suggesting an anterolateral papillary muscle origin, and then the third one, less frequent, a posteromedial papillary muscle origin. But the patient exhibited this bidirectional phenomenon between the anterolateral and the outflow tract arrhythmia. We decided to ablate first the most frequent PVC, which was the one located at the outflow tract, the summit region, and the earliest activation, you can see here that's 42 milliseconds previous to QRS onset, was located at the left coronary cusp. And going over the CMR, we found out that there's a very complex network of connections that's going from one to the other papillary muscle, but also from the anterolateral papillary muscle to the anteroseptal basal region. And in the long axis, you can see that the anterolateral papillary muscle is connected to the LV summit. Interestingly, when we target the first PVC located at the left coronary cusp, we were able to eliminate all PVCs. Regarding the results of catheter ablation, we see that monomorphic arrhythmias tend to have very good results, as we have previously reported, but in the polymorphic group, results are truly poor. So in conclusion, patients with polymorphic papillary muscle arrhythmias have this anatomical triad that's composed of higher counts of papillary muscle connections, an altered architecture of the papillary muscle, which is composed with multiple strands, and a pronounced LV trabeculation. All of this contribute to poor long-term ablation outcomes. And to end this presentation, I would like to mention why these findings are important. We know so far that papillary muscle arrhythmias can originate from the papillary muscle themselves. They can also originate from the connections, but we haven't yet proved whether these arrhythmias may have a stretch-induced mechanism. which is suggested indirectly by the findings of the ablation results on at multiple ectopies that can be ablated by a single site location. Thank you very much.
Thank you, Dr. Santiago, for Yash Lokhandwala here. Very fascinating talk with a lot of things that I was not aware of. A couple of questions. The imaging that you did, for example, in the left coronary sinus, showing the site of the catheter, was that using how was this done in this imaging in the cath lab?
I guess you referred to this one. This
Yes.
is an intracardiac ultrasound view of the aortic root, and then you can see here the ablation catheter that was placed in the left coronary cusp.
Okay.
The arrhythmia, the first PVC suggested a possible epicardial location, as you can see this pseudo delta wave. And our usual workflow for outflow tract arrhythmias include mapping either the RBOT, the coronary sinus, and the coronary cusp as well, to see, as it's a very complex region, we try to get the earliest activation throughout all these structures. And interestingly, this patient, even though you see that the earliest activation was coming from the left coronary cusp, this doesn't mean that actually the foci may be located deep at the summit region, which is exactly where we saw this connection go into.
So, if I understood correctly, you showed an example where the papillary muscle has a connection to the summit region. Am I understanding correctly? So that means even outflow arrhythmias which are not able to map the earlier site sometimes could be related to the papillary muscle. Is it possible?
Well, in this case, we have a very frequent PVC triggering that was coming from the outflow tract, and we secondarily saw these papillary muscle arrhythmias, which are very different anatomical locations, and we tried to explain why the patient was having three morphologies at the same time. And I'm showing this slide again because it really calls the attention that the three PVCs that this patient is showing from these three different structures are showing a very complex connection network on both papillary muscle. And as you can see here, it's a web pattern that goes from the posteromedial to the anterolateral, and then it continues to the outflow tract region. And in the long axis of this CMR image, you can see the trajectory that it's going straight to the outflow tract. So one hypothesis is that you may be having one ectopic site at the LV summit, and that ectopy may be collaterally triggering some stretching phenomenon over the other two structures, which are the papillary muscle. Once we got rid of the first ectopy, we got rid of all of them, including the papillary muscle parts.
Fascinating. My last question is that, there are some of these patients who have unifocal PVCs. They may be outflow or they may not be, but more commonly outflow. Unifocal PVCs, very frequent on a Holter, but only when they get couplets, the second of the couplet has a different morphology. I don't know if you've seen these, but I've seen quite a few of these patients. And then we think they're multifocal PVCs, but why should that be? Because all the rest are the same. So is that something similar to analogous to what you've described here?
Well, one of the reasons to see that, because there's many ways of seeing multiform PVCs in the papillary muscle arrhythmia groups. But when you see that a couplet that the second beat is usually different from the other, then you can either have this, which is the bidirectional arrhythmia, and you see clearly that this patient may have one single PVC, as you can see the isolated bit here. And then when you have a couplet, you have somehow a different transition zone, but it's clearly that the axis actually shift from one point to the other. So the connecting structure between both papillary muscles may well represent a reason either for stretching mechanism or for conduction mechanism between both structures. And the other possibility is that you may have a connection that the same papillary muscle may present one connection away from its base that may allow for either reentry or for multiple foci to have different exit sites throughout the couplet.
Thank you. Ullas, do you have any question, or we can then move to the next? I think Santiago, thanks a lot again.
Yash, I was asking a question.
Yeah.
Dr. Rivera, wonderful presentation. See, when we are ablating the so-called polymorphic PVCs, where the mechanism is the different sites of exit. So essentially, we are ablating the exit site according to your methodology. Were there occasions you went on chasing, the different morphologies? One exit site you ablated, it started coming from the other. You ablated that site, and it really was like a chasing game. Has that happened? Number one. Number two, when we are looking at this exit ablation, not necessarily the focus. And if that is like, for example, a papillary muscle, you think we should isolate the muscle electrically? Is that the best way?
Well, that's actually an excellent question. There was a time at which I did so because when you have polymorphic arrhythmias, then you have to target multiple sites, and it has been described that very frequently, even during RF delivery, that you may have a switch in morphology. Whether the patient has that natively or you are inducing that during RF ablation. So polymorphic arrhythmia ablation is very challenging because you have to target several sites, and finally you might not get the result that you want. Then the isolation of the papillary muscle base, it's been proposed, and there are several studies about that. But I've done so myself, and you can get a reduction on the PVC burden after ablation, but it is almost impossible to electrically isolate the papillary muscle, because if you go back to the anatomy, then you see that the Purkinje junction area, which is located at the base, it is not only circumscribed to the endocardium itself, and you are surrounded by LV trabecules. So it is very hard to isolate the papillary muscle on one side, and on the other hand, I'm not sure that that's something that we should do, because it haven't been really studied deeply the possible outcomes of electrically isolating a papillary muscle with regard to papillary muscle dysfunction. When you ablate at the base of the papillary muscle, there's a very high chance of steam pop formation, and steam pop are very important things to avoid, as they can dissect the muscle and cause pericardial effusions. Are mostly required to be addressed by surgery. So that was something that at some point I've tried with not very good results, but I wouldn't actually recommend nowadays.
Thank you, Rivera. Dr. Yash, to carry forward.
Thank you.
Thank you, Santiago. We move to the next topic of the idiopathic ventricular fibrillation, which has been an enigma. And now that especially we have quinidine available in India, it will be even more relevant to us. Paul?
Thank you. I'm setting up the presentation here. Well, thank you again for having us, and also for being able to share this presentation, which is on idiopathic ventricular fibrillation. And to the audience, there's two important messages. First of all, keep in mind that all of the pathologies in arrhythmogenesis that we discussed are related to the normal heart, to the apparently normal heart. So you think from the outside, there is nothing structurally abnormal, and still there can be major disaster. This is the third topic in that row. I have a few questions on the way, so if possible, to the audience and from the audience, please interact with me on a few questions, general questions, so they are not very difficult questions, but just to have a bit of input from your side. What I would like to do is to discuss the current knowledge on idiopathic ventricular fibrillation, in particular, the importance of complete phenotyping. I like the word phenotyping, as you can tell from my introduction as well, because we have to do better as cardiologists to understand complex pathologies. VF triggers and incident PVCs that make the arrhythmia to come forth as fibrillation. We have to discuss databases on idiopathic ventricular fibrillation and why they are important, the familial context of a patient, and the value of ECG imaging. Let me ask a question first, and that is, which primary electrical disease that you know that was originally labeled idiopathic was later identified as a separate syndrome, and when? Just a few hints in terms of answers may be enough before we continue. And if you feel like you put it in the chat, then that's perfectly fine. I can see your answer there. Anyone? Or should I continue?
So, Paul, Yash here, I'll stretch my neck because this entity called idiopathic VF was probably the longest series, and there has been Professor Belhassan from Israel, who is more than 30 years of follow-up. But really, it's been a little bit, you know, the definition has not been very clear to my mind.
So we will get to the definition, but talking about primary electrical disorders that were originally labeled idiopathic, you can think of the one on the next screen, not the one, the many on the next screen, starting with long QT syndrome in 1957, as you can tell from this old paper from Jarvel and Lange-Nielsen, all the way to TPVT, Brugada syndrome, short QT syndrome, early repolarization, a couple variant of Tourette, and then there is another couple of rare syndromes related to genetic causes. I can talk with you for hours on this topic, but there's no time for this. So it means that what originally a wide spectrum of primary problems, primary electrical disorders, has gradually decreased to what remains as cases of ventricular fibrillation, where with the best of efforts that we do, and I'm sure you have many, many of such cases in India, that you can still not find a good explanation. This particular group, the ones that remain, the ones that you cannot identify with a diagnosis after thorough investigations, that is exactly the syndrome that I'm talking about. So what do you do in such a case? In the case of a patient with ventricular fibrillation with an apparently normal heart, well, to get to that point, to get to the conclusion of a normal heart of diagnostics, you have to go through a good cardiography. Usually in our country, we do toxicological screening, we do Holters, we do echo, we do exercise, we do coronary imaging, we do MRI, and we even go through provocations like with sodium channel blockade or even cardiac coronary spasm provocation. And if all of that is done, and that only is needed, or that is needed, not only, that is needed, then, and it's all normal, then you talk about idiopathic ventricular fibrillation. So here is a case. This is a male of middle-aged age who was brought to the cardiac care unit in a hospital nearby. And you can tell from the couplet and the triplet on the screen that there was activity coming from the right ventricle. Look at how the coupling interval of the first ectopics, the ones that I point here with the laser, have a relatively long coupling interval of more than 400 milliseconds, but that will be different on next slide. So the guy was brought in earlier that day with ventricular fibrillation, and you can tell it from the screen. These are the screenshots from the AED, the one that led to defibrillation. Unfortunately, the guy was safe, and by now, still he was well with an ICD. But if you look to his cardiac workup, and in 2018, in that same year, he had a normal ECG. There was really nothing you can tell. Also, when you look to the signal averaged ECG, actually the one that was discussed by Dr. Pandurangi in the previous presentation by Job Stocks, there was nothing abnormal. The values here are within the normal range. This was what happened on the cardiac care unit while the guy had a 12-lead ECG on. And out of nothing, the same origin of focus, not exactly the same morphology, but roughly the same origin of focus, and with a much shorter coupling interval, led to the induction of ventricular fibrillation. He was defibrillated and later treated, and then everything was fine until this very day. We did the workup. We tried to establish whether indeed this is a normal heart electrically, or not electrically, structurally, starting with asthmaline provocation testing, showing nothing like Brugada syndrome, doing the cardiac MRI, which did not show significant abnormalities, although there was a moderate band that was rather prominent. And it led to a little bit of dyskinesia in the RV region, but there was no late gadolinium enhancements indicative of fibrosis in both the left and the right ventricle. And you've seen this picture before in the presentation by Dr. Stocks. This is what we then often do in these cases, especially in what we call the hot phase, when they had just had their ventricular fibrillation. To do ECG imaging on them. And of course, you remember from the presentation of Job that these were the images of normal people, a male and a female. Now, what do you find when you do ECG imaging in a case like this one with idiopathic ventricular fibrillation? Well, what you find is that activation here pointed at the left upper side where my laser goes is normal. This is a normal pattern of activation. The timings are normal, etc. But if you look to the repolarization using ECG imaging, again, in this non-invasive electroanatomical imaging of the heart, then very often in these cases, you find very interesting islands of early recovery and very dense electrical gradients from those regions with early recovery to the rest of the heart. So that suggests that these islands could be a distinctive feature of those hearts, at least in a subset of patients with idiopathic ventricular fibrillation. And this was further investigated by assistant professor Dr. Matthijs Kluitmans, who actually introduced the technique of ECG imaging in Maastricht. I adopted it from the group in St. Louis, the famous professor Joram Rudy. And when he compared features on the 12-lead ECG with the features of ECG imaging, he found that, well, the 12-lead ECG did not really tell much about the distinctions of idiopathic VF patients versus the control ones, but ECGI features did. For instance, when looking to a maximal gradient of local recovery time. And the same holds for when he looked to T peak to T end values on the 12-lead ECG, which were not significant for patients with idiopathic VF, where the marker called RT surface ratio, which is a kind of index of electrical mass of regions with a short recovery versus those with a normal or a bit longer recovery. So what is the balance of these two regions comparing the island with the rest of the myocardium? Is that somewhat imbalanced, or is it really much different? No, when it is imbalanced, then that makes higher chances of inducing VF. And that also brings to this slide where the overlapping of these features is clear. If you look to the control group, there is no ectopy, so you will not find a blue dot. And there is, in general, little overlap between regions with a maximal gradient or regions with a higher RT ratio, the one with the math and the balance between the regions of early and normal. The PVC group, which is a monomorphic PVC group with long coupling intervals, did not really overlap. And when it came to idiopathic ventricular fibrillation, you can tell it from the screen. There was a high overlap. So it is as if a perfect storm comes together by all its elements. Now, again, a question to you. I have 4 questions in total, and they will go fast from now on. Do you or does your institute keep any record on cases of idiopathic ventricular fibrillation? Do you have a kind of database, or do you have anything that somehow well, reminds you of a previous case whenever you see the next one? Anybody?
Yes, Paul, Yash here again. So these cases are so uncommon. Though we say we just reviewed that they said 5 in Belhassan series. He said that 5 to 10% of all VF are idiopathic. But I think his is biased because he gets all these referred from all over Israel. But yeah, we probably have 4 or 5 patients so over the last few years. So we definitely keep records of them, and especially we had no therapy. And now we have quinidine available in India, so we're calling all of them to take. Otherwise, it was very paradoxical. Quinidine was manufactured in India, but not available in India.
Yeah,
now
that's
it
a
is.
shame. Yeah, that's a shame, Yash, and it shouldn't be, because I know you have been the major and most important producer of the agent, and it should be available to your cases. But you're making a very important remark, and that is in quinidine. Thank you for the response, and I would be very interested after this meeting at any point to discuss these cases with you. Thank you for the response. So here is another case. A lady also in her 50s, or late 40s, I believe, when she got VF. When this was picked up in an emergency situation, when this case was investigated also in the EP lab, and Dr. Rachel Becker, who is presenting after me, actually did a EP procedure measuring ectopy from the endocardium, mainly from the Purkinje fascicular system. She found in connection to these, again, RV free wall triggers, that there was Purkinje potentials in the region from the first moments of electrical impulse formation. That brought us again to do the ECG imaging. This is during a sinus rhythm situation. This is when we looked to the recovery map. So the upper one is activation, normal activation. The second row is recovery with high gradients. And when you speculate on the mechanisms, and you find that the first activation from a ectopic beat comes from the region with the early repolarization, probably hits onto block of not yet recovered myocardium, but finds a way around, and then that re-entry into motion, and then from there VF starts. Which also brings to the other question, and this is my third question, if I'm correct, and that is, what is the dominant origin of triggering PVCs in human idiopathic VF? I'm almost there. I'm almost at the end of my presentation, but
I think, Paul, though
Yeah.
I'm answering, I am sure all my colleagues will agree that our thinking is that most common source of triggering PVCs is the fascicles,
Exactly.
predominantly the posterior fascicle, which we call the angry fascicle.
Exactly. Oh, the angry fascicle. That's enough. We keep that in the terminology. And indeed, that was shown already more than 20 years ago by the famous group by Michel Hasseguer in Bordeaux in France, where they looked at that time to 16 patients, finding that in the majority of them, the endocardial side, the Purkinje fibers from the right ventricle or the left ventricle, or both of them, were the sources of first ectopy in these hearts. So we have to do a bit of work still in the coming years to connect the endocardial sources of ectopy with the substrate of susceptibility with those regions of early recovery that I showed you on the basis of the ECG imaging, to find how exactly, as hypothesized in the last case that I showed to you, and how exactly the ventricular fibrillation is set about. And this is also related, of course, to the anatomy of the fascicular system, the posterior angry fascicle, as Yasha mentioned, or other fascicular systems in the heart, and how they can be anatomically different. So I conclude with this slide. This is my last slide, and just to recapitulate based on a overview of Michel Hasseguer in 2019, that the combination of conduction abnormalities, but notably repolarization abnormalities and excitation abnormalities in the form of abnormal impulse formation, is the crux, are the elements of the perfect storm that once can happen and then struck very deadly in the form of idiopathic ventricular fibrillation in the apparently normal heart. Thank you very much.
Thank you, Professor Waldes. It was an absolutely a great presentation, and you made the presentation very interactive as well. Very nice. So what I understood from your presentation is this term idiopathic VF is rapidly fading away. And the origin of the so-called idiopathic VF could be traced to either myocardial substrate or an electrical substrate. That was beautifully conveyed. Now I understand that this ECGI is actually unmasking these substrates. So I have a few questions here. With the ECGI, can you make out the so-called electrical substrate versus the myocardial substrate from the ECGI?
I think you can do so, Olas, but to a limited extent. We do not claim that using ECGI, you can unravel all the elements that make idiopathic VF. But what we do find, and this is important as a development in the field, is that we pick up important substrates of susceptibility that seem to vary over time, or at least are abnormally present at moments that VF has just occurred. That means if you look to the heart in sinus rhythm after a patient has recovered from VF, and you do so in the early phase after, meaning within a couple of days, then what you see is this specific feature of the what we call them islands, or we call them zones of early repolarization, as opposed to other moments in life when you do the whole procedure again during times of stability. And actually, Dr. Job Stocks, the first speaker of today, is doing this research on already more than 60 cases of idiopathic VF that we did with ECGI. Then the hot phase, the early phase after VF, and the late phase that we call the cold phase can be quite different. So without going into too much detail, we can do, but there's no time, and we can do it separately. Without going there, there is differences in the way that the substrate of susceptibility shows up and is very much linked to the moment that VF has just occurred.
You have some experience about integration of the sophisticated MRI images with your ECGI, where the diagnostic yield was better and the idiopathic VF, so-called, was not there.
Mm-hmm. Yeah, we have. And in fact, another feature of the team, what they achieved is that we can also do ECG imaging in connection to MRI at the same moment. Well, not at the same moment, but just a little bit apart. Because we have these strips that with the location of the electrodes at the same position as during recording this body surface mapping. But these strips, they mimic the position of the electrodes, and you can put the patient with those strips, with those mimicking electrodes in the MRI, and then you can make it even one-to-one for the same patient at almost the same moment. So yes, we are able to connect electrocardiographic imaging together with the structural imaging of the MRI for the same patient within a relatively short time span. And that makes it very interesting because then you can also start to look into other features. For instance, mechanical abnormalities of the myocardium, not just the electrical ones, where we think, and this is also work done by our next speaker, Dr. Rachel Delbecke, where you can look to electromechanical aspects of the heart, where we think that in many cases, as also alluded to by Dr. Rivera, there may be mechano-electrical connections that explain the occurrence of arrhythmia. Whether that is also the case in idiopathic PF, we don't know yet, but at least the possibility to investigate is something that we are very much into.
Yeah, I think Australian group is doing a radio ablation in real sick patients where invasive studies are not, they are not safe. Such sick patients, I have heard certain centers in Australia, they're doing radio ablation, making use of the integration of this ECGI and the MRI.
So do we. So do we. So we
oh,
already did 4 cases. And again, more questions, ask the next speaker who is leading that program here in Maastricht. Yeah.
Well, I have one final question.
Yeah.
The first of your slides, which showed your workflow in calling a person to have a idiopathic VF, I thought genetics was missing from that list.
Yes. Well, that's not good because it should be on. If it misses, then
I thought so.
And then you're absolutely right. I have the slide here. Yes, genetics is genetics is my core business, Ola. So I should have added it.
Oh, you should have added it. I thought you really didn't value that much because I don't know. There are certain variants of some no significance or questionable significance. It adds to the confusion. So I was thinking you do not like genetics.
No, I do like genetics.
It is just that you did not add
I earn a living in doing so, but I should have added it here.
Walters, it was fantastic to listen to you and to interact with you. It's my privilege.
Thank you very much. And again, I look forward to interact more. Yeah, I stop share because we have a fantastic presentation to come. Please all stay tuned because the next one will be fantastic too.
Yeah, Dr. Rachel, I hope I'm pronouncing the name correctly. So, for us, Provocate, really an interesting topic for us, for pediatricians, because for us, it's limited to oral flecainide, to be very frank. And you may not know that Ajmalin, as we are taught, came from an Indian patient called Ajmal Khan, but we've never had Ajmalin in India. So I think we're very interested to listen to this talk of yours on the provocative testing for the genetic inherited arrhythmias.
Thank you very much. I hope you can hear me well, and thank you for having me on this virtual India screen. So I've never been to India, but now I feel a little bit in India. So thank you for inviting me. It's a great honor to be here. My talk will be about provocation testing, but by the end of my presentation, you will also be able to recognize ECG signatures of various primary electrical diseases, master the indications of provocation testing, and safely conduct and interpret the results of such provocation testing. So, and this is all why we are here. This is my ikigai. So this is why I wake up in the morning. This devastating event of sudden cardiac arrest and the impact it has on family members, on friends, and on society. Trying to understand what is happening and how we can prevent arrest from occurring. So if you are looking to why this is happening to patients that we see, there are many underlying diseases, structural heart diseases that cause sudden cardiac arrest, especially in the elderly population, but in the younger population, usually there is genetic defects underlying, and it has been proposed that in 5 to 8% of patients, electrical diseases are key to the occurrence of sudden cardiac death. So this requires diagnosis, requires a high level of suspicion. And of course, we start with the ECG. That's the easiest thing that we can obtain. Not everybody has ECG-I, but ECG is everywhere. But it can be borderline or even normal in our patients, as Paul has discussed previously. So smart provocation can uncover and help us to understand what is an underlying substrate. It can uncover ECG patterns, but also arrhythmias that can be characteristic of such genetic diseases. Hey, my slide has fallen away, I think. So the first thing you need, of course, before you do provocation is to have a lab and a team that is equipped and knows what to do when proarrhythmia occurs. So you need to have a lab that has an external cardioverter defibrillator. You need monitoring of your patient, 12-lead ECG at least is that how we do it, and continuous blood pressure measurements. You need personnel that is trained in advanced resuscitation techniques, and you need a physician also promptly available that knows how to counteract the drugs that you give. And we always monitor our patients another 30 minutes to 2 hours after the ECG has normalized. Here it is. Maybe you could scan this QR code. I hope it works. And I'd like to ask you, which smart provocations do you employ in your clinic? So you can type it in if you want to. I hope it works. And if it doesn't work, I will move on, but it does work. I will share the screen. You can see what you all type in.
You meant pharmacologic provocation, right?
Pharmacological, yes, absolutely.
So for us, as far as I know, in India, it is basically flecainide.
Yeah, that's the only thing that has been typed in so far. So that is correct. So it's not here. No, okay. So the only thing that you have typed in so far is flecainide, adrenaline. Quinidin comes in, and flexinin. Probably that's also flecainide, I think. Okay. So these are 9 responses. I will go back to my presentation and share that with you. Okay, thank you for your responses. So actually, there are many more, as you already alluded to. So for Brugada syndrome, the most the drug that we use the most is ergomelin, but you can also use indeed other types of sodium channel blockers like flecainide, procainamide, and pilsecanide, which is only available in Japan, I learned. There are different ways of infusing them, but most of them are easily infused within 10 to 15 minutes. And it's, of course, important to know your counter-acting drug, so your rescue medication if things go the other way around. So it's isoprenaline for the Brugada syndrome and the sodium channel blockers. But you can also think about giving epinephrine, for instance, to patients with long QT syndrome or CPVT, catecholaminergic polymorphic VT. And we've been doing this, as Paul has alluded to, in a research project to look for risk stratification tools in long QT syndrome patients, where we give the epinephrine provocation according to the Mayo Clinic protocol. And of course, then it's important to have a fast-acting beta blocker or a magnesium at the site to counteract potential proarrhythmic events. And there is also
sorry to interrupt, Rachel, but just to be adrenaline is different totally from epinephrine.
It's the same. It's the same.
Oh.
It's a sympathomimetic drug that acts both on the alpha and the beta receptors. So it's the same. It's just a different name. Long QT syndrome can also there's also reports on adenosine. So this is the fast blocking of the AV node in 6 milligrams with incremental dosages until you have complete block. And I will come to that later in the presentation. So first, a little bit about how the ion channels underlie the QRS-T that we are so familiar to on the ECG. So you probably all know that there is an action potential shape which is being created by all different sorts of ion currents, inward and outward currents, in the fast upslope of the action potential. So the QRS duration actually is mostly carried by the sodium channel and inward current, and the repolarization or the QT interval is mostly carried by IKS and IKR currents, which are available throughout the action potential dome. And if you have mutations in one of these currents, you can either end up with an LQT type 1 for the IKS current, LQT type 2 if the IKR current is impaired, and if you have an increased sodium current due to SCN5A mutations, you are stuck with the type 3 long QT syndrome. Whereas in Brugada syndrome, the peak sodium inward current is reduced. So this is important to know for the remainder of the talk, because we are starting off with LQT syndrome. So there are, as you are probably well aware, 3 genotypes. So the LQT type 1 due to KCNQ1 mutation usually show on the ECG QT prolongation, but also broad-based T waves. LQT type 2 has a different morphology. Usually they present with abnormal T waves with low amplitude, notches or humps. And the SCN5A mutation carriers within type 3 long QT syndrome, they usually have a very long flat ST segment with late T waves and pointed T waves. So not only the ECG is genotype specific, but also the mode of arrhythmia onset, which is adrenergically driven in LQT type 1, sleep or emotion or auditory stimuli driven in LQT type 2, and in type 3, they mostly have arrhythmias during the night, so in rest. So this is important, of course, to know which type of provocation test to use and which phenotype, which genotype. Because this is what we are all afraid of, to have the short, long, short, pause-dependent torsade de pointe, which is often seen in type 2 and type 3 long QT syndrome, whereas the adrenergic or fast rate dependent during exercise is usually the arrhythmia that occurs during in patients with LQT type 1. So how do we get to the diagnosis? So of course you all are aware of the Schwartz QT score, which gives you several points. And if you have 4 or more points, you are clinically diagnosed with long QT syndrome. But the sensitivity of this score is only at maximal 20%, which is pretty low. So this means that there are people that will not fulfill the criteria and do still have a chance of having long QT syndrome. And the same holds true for the recent guidelines by the ESC telling us that we need the long QT interval to get to the diagnosis, or a pathogenic mutation, which is also not always possible to evaluate, or you have variants of unknown significance. So this is a problem. So, and this is another figure that shows the problem. This is a KCNQ1 family where they have all the carriers of the mutation, but a lot of patients have QTCs that are within the normal range, so about 50% of patients. So this makes the diagnosis of long QT syndrome challenging, and therefore I think there is a place for to improve diagnostic accuracy, a place for the provocation testing. And if you want to discuss about improving personalized risk stratification, this is not part of the presentation, but it's part of a research project that we have ongoing. So this is one of the most feared roller coasters of largest Dutch theme park that is close to us. It's called the Baron. So you go up here and you fall down in a hole. And this is what happens if you go up and you are sitting there and you fall down. So this is what adrenergic provocation does to you. But what does it do to the ion currents? So adrenergic stimulation increases, of course, the sodium current, the calcium current, and primarily IKS. By doing so, the heart increases inotropy, chronotropy, and dromotropy, and IKS makes the QTC shorten so that you don't get into trouble. So how do we do this pharmacologically? There are basically two protocols. One is the Shimizu protocol, which is a protocol of epinephrine bolus, very short bolus, and then 5-minute steady state measurement, and then a recovery phase. So it's a very swift provocation test. The Mayo Clinic protocol is a little bit more slow. So they take a lot of more time. It's actually a wash-in of a very low dose and then a gradual doubling of the dose over a period of 5 minutes. And then you carefully look at the ECG, the QT interval, and of course, whether there is no reasons to prematurely terminate the provocation test, because there can be problems, of course, if the hypertension goes up above 200 millimeters of mercury, or you have a proarrhythmic event. You need to be aware that you then have to stop the infusion, of course. T-wave alternance is something that we sometimes see. Can be very subtle, so you have to be vigilant. And of course, we discussed what you can do if these things occur to give them esmolol or magnesium. So what will be the main readout of this protocol? Now talking about the Mayo Clinic protocol, it's mostly there to find patients with the LQT type 1. So due to the IKS current, at a low dose of 0.1 microgram, they show a marked increase of their QT interval. And this is very different compared to other genotypes or even healthy controls. And the authors state that an increase of 30 milliseconds or more is indicative of LQT type 1 in 92% of patients. So it's a very high sensitivity, but be aware there can be confounders by genotype negative patients or LQT type 2. And some healthy people, actually a large group of healthy people, show also some QT interval prolongation, but usually this is far less than the 30 milliseconds that have been used as a cutoff. So you have to be careful. The Shimizu protocol defines a cutoff of a QTC of 35 milliseconds at the steady state. So this is at the second phase here as an indicator of LQT type 1. So what about...
Sorry, Rachel, I'll forget it later, but I was a bit confused on this slide. You said normal subjects, 80% may show with epinephrine. So how do we differentiate these from the... I'm still not clear on that aspect.
You filter them by the extent to which the QT lengthens. So if it lengthens more than 30 milliseconds, then you have a 92% chance of having an LQT type 1. But if it's lower than that, there is no clear distinction. So it should be a clear prolongation above 30 milliseconds. And the important thing to note here as well is that you should not correct the QT interval at this point in time, because then you get in trouble with the healthy subject. So it's an absolute prolongation of the QT, which matters.
So uncorrected QT should go.
Yeah, uncorrected.
Thank you.
Yeah, you're welcome. The type 2, this is a little bit different. Here you are not so interested in the QT lengthening, but rather the QT morphology changes. So they often show biphasic T waves. They can show a notching, and whether this notching occurs at the end of the T wave, the arrows have shifted, I see. At the end of the T wave, then they call it G1 notching, whereas it's in the upslope of the T wave, like you see here, they named it G2 notching. So what happens in these patients is that in both controls, LQT type 1 and LQT type 2 show biphasic waves, so this is not diagnostic. However, the G1 and G2 notching is more seen in the LQT type 2, sorry for that. So whereas the early notching, so in the upslope of the T wave, is exclusively seen in LQT type 2. So if you see that, you are probably more assured that we are dealing with an IKR mutant patient. With the short-acting Shimizu protocol, they provide a characteristic that they say, well, if the QTC lengthens at peak, so in the early phase, but normalizes in the second phase, so in the steady state phase, this is something that is characteristic for the LQT type 2. And the reason for this is that in the early phase, ion channels are still not responding to this very fast epinephrine provocation, but IKS can speed up after a while and then shorten the QT at the steady state phase. For LQT type 3, there is no gene-specific response, unfortunately, due to the epinephrine provocation. So we are left a little bit in the dark there. There is no clear goal we can set our heart to. In the Mayo Clinic protocol and also in the Shimizu protocol, it's actually, if you fall beyond the or you have a QTC that is not lengthening that very fast and it normalizes again, then you end up with the LQT type 2. But if it doesn't normalize or there's no inspecific response, you are either a control patient or an LQT type 3. So this doesn't help you actually. And I didn't find any other pharmacological change that pharmacological provocation that helps us here. The adenosine provocation, so this is a very fast-acting AV blocking agent with reflex tachycardia afterwards. This is interesting because you have a dual response. You will have the slowing response after 30 seconds or so, and you have the tachycardic response later on after 1 minute. And what they have described, the authors, so Sami Viskin from Israel, has shown that especially in the bradycardic phase, you can see very absurd T-wave morphology changes and QT lengthening. And if you see a QT lengthening of over 410 at maximal bradycardia, is a very high sensitivity and specificity to detect LQT type, LQT syndrome. There's no genotype specific responses reported in this publication, and they didn't look into the risk stratification aspect. So the conclusion on this part is the biggest part of my presentation. So the recommendations for provocation testing, it may be of help in patients who will not or cannot be genotyped. And I don't know what the situation is in India, whether you have access to genetic testing, but there it may be of help. but also in patients that have been genotyped with a diagnosis but have an unremarkable resting ECG, or they have a novel mutation that you don't know whether it's pathogenic or not. It is not recommended to provoke with epinephrine in patients with type 3. And the adenosine may be a better simulator of physiological stress by provoking first a bradycardia and then a reflex tachycardia. So now we proceed to the Brugada syndrome and the Ashmolin provocation. So as I told you previously, Brugada syndrome is mostly attributed to loss of the peak sodium current, which you can sometimes visualize baseline like the type 1 Brugada ECG, but often it's not present and you have to give a sodium channel blocker. And this is actually a case that I did last week. This is the baseline ECG that we recorded before. So it is actually no clear abnormality. There's normal PR interval, normal QRS, no ST segment elevation, also not in the higher intercostal spaces. But when you give Ashmolin, and this was only after 6 milligrams per kilogram, this lady developed extensive QRS broadening and ST segment elevation of the cove type, reaching values over 2 millimeters and a terminal negative T wave that you can see in consecutive leads. When do we do an Ashmolin provocation testing? We only do it in patients that have that don't have a type 1 Brugada ECG spontaneously, and that have additional features such as a family history of Brugada syndrome, family history of sudden cardiac death, or that had an arrhythmic syncope in their history taking. We don't give it to asymptomatic patients. And I will not go into the hypothesis behind the Brugada syndrome, but rather move on to the differences of different drugs that you can give. I told you previously, but there is a mechanism of action that differs between Ashmolin and flecainide. The flecainide that you give also inhibits the sodium current to the same extent as Ashmolin does. But the difference with flecainide and Ashmolin is that flecainide is a more potent inhibitor of the ITO current. And the ITO current counteracts actually the sodium channel inhibition. So it makes it less efficacious to produce the Brugada phenotype than Ashmolin does, which only has a minor effect on the ITO current. The other thing is that flecainide is a class 1C antiarrhythmic drug, which makes it slowly dissociating from the sodium channel, which therefore gives a longer lasting effect as opposed to the class 1A drug that Ashmolin is, which rapidly dissociates from the sodium channel. And the other property is, which I really like, is that it has a very short half-life. So it's only 6 minutes, but it takes a little bit longer to get out of the system. So we do monitor the patients longer for 2 or 3 hours, but it's a really short-acting drug as opposed to the 13 hours of half-life of flecainide. Procainamide we never use, and also this one we never use clinically, at least not in my clinic. And then it has been shown by Christian Wolpert that indeed Ashmolin has a higher efficacy than flecainide for provoking the Brugada syndrome ECG, the Brugada ECG, I mean. So I already told you it's important to put your ECG electrodes higher up the outflow tract. So we usually put them at the third intercostal space, and then at maximum dose we switch to the second intercostal space. And sometimes what you can see is also this alternating pattern of the type 1 Brugada ECG. So this is something that, I don't know, has not been published before, and if it's arrhythmogenic, but I sometimes I see that. But reasons to stop the provocation, of course, is if you see the type 1 Brugada ECG, when you see premature ventricular beats, when you have non-sustained VTs, and they will always tell you to stop the infusion when you have 130% increase of your QRS complex. But the trouble with that is that 40% of the tests will only become positive at higher dosages. So we usually do not stop the infusion after 30% increase, but carefully monitor for arrhythmias afterwards. And then a word of caution on the clinical interpretation of an Ashmelin provocation, because this is recent data from SNAM in circulation, which was a very interesting paper. They looked at Ashmelin provocation in healthy subjects, and these are healthy subjects that have normal clinical testing and no family history of sudden cardiac death, but still they have a 3% of them have a positive Ashmelin test. So this is something that we need to be aware of. And on the other side, if you have a patient group, this is work by Probst in France. If you have a family group of patients that have a known SCN5A gene defect running in the family, and you look at those that have the mutation versus the family members that don't have the mutation, if you put all of these patients under an Ashmelin provocation, not every patient with a positive genotype will have a phenotype that is, or will have an Ashmelin, positive Ashmelin test. So 30% of patients that have the gene will not develop Brugada type 1 under Ashmelin provocation. And likewise, patients of family members that are not carrying the mutation, and 15% will develop Brugada type 1 ECG. So this is very difficult to take along in your clinic, but you need to be aware that this is sometimes happening. And then the other thing which is clinically very important, is although people can have a positive Ashmelin provocation, their cardiac event rate is rather low if they haven't had a syncope or an aborted cardiac arrest in the past. So this is only 0.5%. So this is why we don't usually perform Ashmelin provocation tests in an asymptomatic individual, because it doesn't help you in risk stratification. Now, a final word about a catecholinergic polymorphic VT, which can be easily picked up if you have a positive exercise test. It is usually attributed to leaky ryanodine receptors that are in the sarcoplasmic reticulum that leak calcium out of the SR, and calcium that can be proarrhythmic by causing DADs or EADs and then resulting in nasty arrhythmias. Epinephrine provocation is something that has been described to be more efficacious in patients to uncover the bidirectional VT phenomena than just an exercise test alone. So 63 patients that are known with CPVT have a positive exercise test compared to 82 patients if you would provoke them with epinephrine. It's important to know that having just PVCs is not enough for the diagnosis. You really need complex ventricular ectopy or even bidirectional VTs, as we see in this patient. So this is my the last slide. The take-home messages. Provocation testing can indeed unmask the diagnosis of Brugada syndrome, long QT syndrome, or CPVT if the ECG is not diagnostic. It is particularly useful when there is a context of syncope or cardiac arrest, or when there is family screening necessary. And the value of provocation testing in arrhythmia risk prediction remains to be determined and is at this point not recommended so far. So with that, I would like to thank you and for your attention, and I would be happy to take any of your questions. Thank you.
Thank you, Rachel. I took home quite a few points from your talk. Before that, to apprise you of the situation in India, we do not have intravenous flecainide. So most of us have been using oral flecainide in varying doses from 200 to 400 milligrams. And we keep the patients overnight in the ICU. I think what I learned from your talk was we probably underdoing the epinephrine testing. And we do have genetic testing available now. It's a bit expensive for the first patient, but for the index case, then it's not so expensive. But the results come after 6 weeks. So I think one important message that I learned from your talk, apart from, of course, refreshing my knowledge of my channels, is that we should be doing more of epinephrine testing in suspected long QT and also in CPVT, because our traditional thing has been do an exercise, and if it's normal, then leave it alone. We probably should do an exercise first, and if we don't get, then do epinephrine test. We have been here doing sympathectomies quite reasonably in reasonable numbers in patients with long QT with very good results. And we have been avoiding long QT3. So I think that goes in sync with your talk, where it doesn't seem that the sympathetic drive seems to make much difference to the long QT3. So my question, one pointed question, was I was a bit taken aback by the Sammy Wiskins data that with adenosine you get a, I mean, my traditional thinking was a QT more than 450 is where you start thinking of long QT. And he says that with adenosine, with bradycardia, QT more than 400, so I was a bit confused with that statement.
Yeah, I agree with you completely, because you would expect in the bradycardia the QT to be even longer at some point at least. Whereas it maybe, I don't know why he finds that 410. I agree with you, because also in the figure that he showed, it's longer than that. Longer. We have not used it as a provocation test to diagnose long QT syndrome, the adenosine. We do use it now in this risk stratification study that I was telling you about a little bit, where we then look at both the ECG imaging. We give the long QT syndrome patient a vest on, and then we look for repolarization disturbances during this bradycardic phase. And not only we look to the repolarization, but also to mechanical aspects, which I haven't touched upon, but we can discuss separately, because we know that the mechanics is also abnormal in long QT syndrome patients. And as in response to your first remark, with the sympathectomy, we have little data on sympathectomy in long QT type 3 patients as well, but we know from studies that although they are not really adrenergically driven, that they do respond to beta blocker therapy. So there's probably also if you are stuck in a patient and having a lot of arrhythmias, maybe it would be worthwhile to try. Or maybe try with a pharmacological block before and then proceed to a complete block.
So before I hand over to Ullas for his question and concluding remarks, one last clarification. When you do epinephrine testing in long QT, that means how long do you keep the patients in the, if I'm doing it in the ICU, we don't do it in the cath lab, we do it in the ICU. How long do I keep the patient in the ICU?
We keep them for 1 hour after the baseline, return to baseline for 1 hour, and then they go home. And we try to stop the beta blockers always before. We tailor it down because that will it will impact on your results. So we try to stop that before.
Okay. Ullas?
Professor Walters has raised his hand, so I welcome him to make some comments.
Well, I was only referring to two questions that came in through the chat box. The first one is, and this is both for Dr. Tabecke, how to risk stratify type 1 Brugada syndrome without symptoms. You can address that. And the other question comes from Dr. Mohammad Yunus, who says, please elaborate once paradoxical QT response happens in long QT provocation testing. So the first is on Brugada syndrome, the other is on long QT. I'm not sure if the people are available.
Yeah, thank you, Paul. Thank you for reading those questions. So the asymptomatic Brugada patients are very low risk of developing arrhythmia. What you can have a look at is, for instance, the baseline ECG. So is there a fragmentation of the QRS? Is there a very long PR interval? So do you have the idea that there is a lot of delay in your activation of both atria and ventricle. We sometimes put the patients in the EP lab, but this is something that we don't often do. Usually only if we have the idea that this is really a nasty looking ECG, or there is a family history that is very disturbing. Then sometimes we put them in the lab and do a VT stimulation, looking for refractory period and inducibility with only minor stimulation. But this is somewhat thin ice. But if you discuss with your patient the reason why you are doing so, this may be of help. And if we have any concern, we do not put in an ICD. We try to give them loop recorders to pick up asymptomatic arrhythmias. So this is the way we go in this direction. And the other question that you had was regarding the paradoxical QT.
Yeah.
So what is actually the question? I will go back to that slide maybe.
I think the question as it was put is, please elaborate once you see the paradoxical response in the provocation test. So what do you do then? How do you take it further?
Yeah, I think it depends on what your question is. If you think your question is, I don't have genetic testing and I want to know whether it's a long QT 1 or 2, or how to go about, then if you have this paradoxical increase after 0.1 microgram per minute, you could easily say we stop here. Because why would you go any higher and have the chance of a proarrhythmic events? But if you don't have the paradoxical response, I would go through the end of the study. We have now done a couple of patients, I think about 30, and we have not seen any proarrhythmic events with the epinephrine provocation test. Sometimes you do see some PVCs, but we have not had complex arrhythmia, so that we had to preterminantly stop the test. We did have one patient that showed T-wave alternance on the ECGI. So that's why we stopped that perfusion, but that's the only case that I remember that we had to stop early. So it seems to be rather safe. The one that I showed you in the final part of my slide, the CPVT case, this was actually a Friday afternoon patient. And this one, and he was admitted because of a syncopal event. The ECG was completely normal. The exercise test was completely normal. The only thing that happened is that he developed prominent U waves from lying down to standing up position, and he was put on my program to do a VT stim. I said we don't need to do VT stim. We need to do an epinephrine provocation, and then I did, and I got this ECG bidirectional VT, but then it went into a very broad sustained monomorphic VT, and luckily it went away. But this patient ultimately had a KCNJ2 mutation found, but it was only after that we provoked him. So sometimes you can be treated with some nice results and also diagnose in do it. So.
Thank you, Rachel. Fantastic talk on the provocative tests to unmask the genetic arrhythmia syndromes. I agree with Dr. Yash that in our practice we don't do much these epinephrine challenge or stress test, the treadmill test to uncover the long QT syndromes. It's because I think the calculation is very tough. When I myself had tried to do it, to figure it out that 35 or a 40 millisecond increment, it's really very tough. I wish the numbers are large enough and then easily visible. However, I agree with you that the adenosine testing, which is not so very popular, I think is a great idea where the visibility of the changes is so great. So that is what is my comment, why we do not do the treadmill or isoprenaline or epinephrine testing in this. I have a question to you. not often, but not uncommonly, we see this group of patients who have been called bradycardia dependent polymorphic VT. Typically, when the patients got admitted for pacemaker because they have a significant AV block, and there are instances of these happening in one subset of patients because that's not a uniform presentation. Is that a case of a long QT associated with an AV block, or it is just that the AV block in that patient has caused long QT? Maybe this is a different set of patients. Here we stop with a pacemaker, or we should be considering a defibrillator. In all those patients, my experience, putting in the pacemaker, we usually do the dual chamber pacemakers. I do not know the single chamber in such kind of patients. There was never kind of incidence of a sudden death in them. So bradycardia patient requiring or not requiring a pacemaker, but then there were episodes of a polymorphic VT. What are your comments about it?
Yeah, that's actually a very interesting situation that you describe, because also from the work of Mark Vos, who also was in Maastricht, maybe in the time that you were there, I don't know. He has a model on AV block, canine AV block, and that's actually a very good model to study torsade de pointe or polymorphic VTs, because purely due to the AV block and the remodeling that comes along in the ventricle, it makes the heart more prone to get these types of arrhythmias. And I think you are quite right to just put in a pacemaker and reverse remodel the ventricle, maybe even have an his bundle area or a pacemaker that would not result in RV only pacing, but maybe restore the electrical conduction as a whole. And sometimes we do see these patients, for instance, the SCN5A patients, they have mutations in the SCN5A, not only developing Brugada syndrome, but also getting very severe AV nodal conduction delay block. So it may be even so that you are looking at a loss of function SCN5A problem that will result in a polymorphic VT, not due to the long QT syndrome, but due to loss of SCN5A and then structural remodeling in the ventricle.
Thank you, Rachel. There is one more question. I don't think you mentioned about the provocative test in the form of a treadmill test to unmask the Brugada pattern.
Yeah, no, I didn't talk about it, no. Because I thought, yeah, but it's true. You sometimes do see during or immediately after the exercise test, the type 1 Brugada ECG coming about. I think I have about 5 cases collected, and it has been published in literature as well. So I always look at the exercise test also in Brugada patients, especially there. Yes, you're absolutely right.
So you do that first and then the Fleckenstein challenge.
Yeah, no, the Ashmelin, yeah.
Ashmelin.
I always do a complete workup, non-invasive workup before going to the Ashmelin provocation. So there need to be no structural abnormalities or severe conduction problems or indeed a spontaneous type 1, which may be exercise induced or fever induced, because then you already have your diagnosis. You shouldn't put the patient to the risk of, because there is always a 1% risk of proarrhythmia.
Rachel, I have another question. In the evaluation of syncope of undetermined origin, do you uniformly do this Ashmelin challenge?
No, not standardly. We do it in idiopathic VF cases, of course. If we have severe arrhythmia documented, then you need to do it. But I don't know whether you should put everybody that has a malignant syncope to this test. Also, in reminding the positive healthy population, I think there is a genetic background in 3% of patients that is susceptible to Brugada, to the development of a Brugada type ECG, but doesn't mean that they are all at risk. So,
but I'm sure you are aware that there are groups who include this uniformly the adrenaline test for the evaluation of syncope of undetermined
yeah,
origin,
we don't do that.
which I think there will be a lot of false positive cases in
Yeah,
that.
I think so too. Yeah.
Yeah.
And you give the
So,
patient
Ullas, sorry, go on.
I just wanted to say that then you also give the patient a diagnosis that you don't know. What it has a lot of consequences.
So thank you, Dr. Rachel, and all the members from the Maastricht and from Argentina. Yash, I think you can make some final comments. You know, it was absolutely a privilege to be closely interacting with such big stars of cardiac electrophysiology, specialized in idiopathic ventricular fibrillation. Their diagnosis by newer technology like ECGI, and then we talked about the actual mechanisms of the VF structure, microstructural, electrical, how to uncover. It was absolutely a great learning experience for me. And then there were about 80 Indian Heart Rhythm Society members who attended this. I'm sure they also learned a lot. And I think this particular session is going to be changing their practice in evaluating the syncope or sudden cardiac arrest survivors, and then the management. I'm grateful to all of you, and thank you, the IHRS, to get me inside here. Thank you, Ashish. Over to Yash.
Yeah. So I just, Ullas, I felt one thing, we struggled to get quinidine in India. I think, as I said at the beginning, Ajmalin was by Dr. Siddiqui from Kolkata, who used in a patient called Ajmal Khan, and that's how the name Ajmalin came. I think we should try to get Ajmalin back into India. It's been a good learning, a great learning, very good learning experience on different types of topics. So thank you, Paul, Santiago, Job Stokes, and Rachel for for taking the trouble to share your Saturday night, Sunday morning with us. And I can end by saying Todzins, which Ullas means goodbye.
Tot ziens.
And
Dankjewel.
au revoir, till we meet again.
Yes,
Let's
and we
see.
make
Thank
next
you.
pictures, yes, and we see how they change over time.
Okay,
Oh,
goodbye.
So,
I think
thank
Ashish
Bye.
is on the way to
Goodbye,
Goa,
bye.
so he's at the airport and unable to join us. So I say goodbye from Ashish also.
Okay,
and thank you, Dr. Monica, for organizing this.
absolutely fantastic.
Okay,
Oh,
bye-bye.
Bye-bye.
bye
Bye.
bye.
Bye bye.